Yeah. Hi everyone, thanks for watching our headache school tonight. My name is Erica Marini. I am a clinical pharmacist. I work here in the headache clinic at the University of Utah, and I'm excited to be here with you guys tonight. We've had some exciting things going on pharmacy-wise in headache in the past year. It's been really exciting to be around those changes. Given that we've had so many exciting new things approved for headache, we thought it was important to kind of take a step back and review our medications once again so we can really place where the new medications are going to fit in our, in our treatment regimens. And so we'll just take a look first at the medications we have in our arsenal, as I say, for prevention of headache. So these are medications that are taken on a daily basis to prevent a migraine or a headache from occurring in the future. These are not things that you generally take once you feel a migraine coming on. They are things to help prevent a migraine in the future. And sometimes they're the ones that are hardest to remember to take because we don't notice sometimes an immediate benefit. That's another important thing to remember about preventive medications, is giving them a fair trial. Each of these medications, we usually ask that patients give them a fair trial of about 8 to 12 weeks, so 2 to 3 months, before we deem them ineffective. Of course, if you have side effects, that trial might be shorter for you. So let's get into it. Before our new medications, our CGRP injectable medications came out, migraine prevention was a really interesting area because most of the medications that we use to prevent migraine were not initially approved for migraine prevention. There are medications like that were approved by the FDA for blood pressure management, for depression, for seizures, for a wide variety of things, and then along the way they were found to be helpful in preventing migraine. And so the first class of medications I mentioned was blood pressure medications. Now, not every blood pressure medication can help with migraines, but there are certain blood pressure medications that we've identified that can be helpful with migraines. The first class of the blood pressure medicines are called beta blockers. These are medications you might have heard of, like propranolol, or atenolol or metoprolol. You might have family members on these medications who have had a heart attack. Another thing they're really used for is for heart attack prevention in someone who's already had a heart attack, or in heart failure. We're using it though for migraine treatment. Some side effects are mostly related to lowering the blood pressure, and we'll see that with all of our other blood pressure medicines as well. We always in clinic make sure that your blood pressure is enough so that you can handle a little bit of a blood pressure lowering effect. And if you do experience some of these, like dizziness, a lot of fatigue, especially if you're going from like laying down to standing, those could be signs that your blood pressure is low. A lot of times this is just an initial side effect and does go away. So important to keep that in mind. If you have some serious asthma, or you already have a low blood pressure or a low heart rate, we would avoid beta blockers and most blood pressure medicines in you. Another class of the blood pressure medicines are called calcium channel blockers. These are things like verapamil, amlodipine are names that you might have heard in you or in someone else that you know. These medications can be used for chronic migraine, but specifically something like verapamil has been actually studied in cluster headache prevention as well. And so we will use this a lot in our cluster patients if their blood pressure is okay to handle it. Some other things that this might cause, sometimes this class of medication can cause a little bit of edema or swelling, such as in your ankles, or constipation. Important to know that side effects don't occur in everyone, and so this might not occur in you, but we do let people know. Other blood pressure medications that we might use and are commonly used for blood pressure are things like lisinopril, what's known as ACE inhibitors. And so it's really great that these are good for migraine because they're actually first-line treatment if you do have high blood pressure. So say someone comes in and they have migraines, but they also have high blood pressure. Lisinopril might be a great choice, or any of these other blood pressure medications. And that's what we're always looking for in a preventive medication. If we can get, a twofer, that would be amazing. We could help your blood pressure and your migraines. Or say you come in with seizures. Or you already have seizures. We could find something that could help your seizure and your migraine. And that's the class we'll talk about next. There are lots of seizure meds that can help with migraine. They all work sort of differently, but they all work on how kind of the nerves are signaling and how they interact. And so that is how they kind of help with migraine. The first and one that we go to a lot is called topiramate. There is the immediate release form, which is what we generally use. There's also an extended release that is only once a day, which can be really convenient. Unfortunately, it's still very expensive, but it's something that in the future, when it's less expensive, or if you tried the immediate release and it doesn't work for you, it can be a great option. So some of the side effects that we do have to keep in mind with topiramate are a lot of times initially when you first start the medication, it can cause a bit of a foggy thinking. This does subside, and so we generally start at a low dose and go up pretty slowly to kind of minimize any of the side effects, including the foggy thinking. We do have to keep in mind that topiramate can increase the risk of kidney stones, so staying hydrated is really important. And if you have a history of kidney stones, it might not be the best medication for you. An added bonus sometimes with topiramate, though, is that it can promote weight loss. So that's certainly just an added benefit. It's not something that we, put you on it for primarily, but it's sometimes just a nice little benefit there. A couple of our older seizure medications can also have benefit in preventing migraine. These would be things like valproate, or Depakote is the brand name of that. Carbamazepine or Tegretol is the brand name for that. Or phenytoin or Dilantin is the brand name for that. These, as seizure medications, all work slightly differently. They all have some data to promote their use in preventing migraines if taken on a daily basis. These older medications, though, they do have a fair amount of side effects. They do have a fair amount of drug interactions, which always gives us a bit of a caution flag. Also in our young women of childbearing age, these medications are really not good in patients who are pregnant or might become pregnant. And so those are some reasons that we kind of shy away from these medications as a first-line treatment, but they are, of course, always things that we can think of. Some of our newer seizure medications, such as topiramate, we use more often because they have a better safety profile, they're generally better tolerated by our patients, and they still have great data to support their use. In addition to the topiramate, there's also levetiracetam or Keppra, which we can use for migraine prevention. Gabapentin or pregabalin, the brand name for pregabalin is known as Lyrica. These medications also have good data for use in migraine. They also can work for other different pain syndromes, neuropathies, especially gabapentin and pregabalin or Lyrica have some really good data for use in neuropathies or those types of pains. And another So NSAIDs are not free of concern, especially as we get older. We do get more concerned with some of the issues with NSAIDs. Some NSAIDs do have a cardiac risk to them, especially as we get older. NSAIDs can also are not necessarily a good idea in patients with diabetes because they can cause kidney problems. In someone, who maybe have to be on an anticoagulant for a different reason, NSAIDs aren't a good idea because they can cause easy bleeding or bruising. And then anyone who takes NSAIDs too often, so if you're taking, ibuprofen, 800 milligrams, 4 times a day, every day, that can be really bad for your stomach lining and can cause bleeding ulcers even. And so not overusing NSAIDs is really important. And so say you are taking one of these NSAIDs as a preventive daily, we would caution against using additional ibuprofen or additional Advil or Aleve on top of the daily NSAID that you're taking to just kind of minimize that risk. Our next version of medications that can be used for prevention are all different types of antidepressants. So migraines definitely have to do with the chemicals that are in your brain, and certainly one of those chemical transmitters in your brain that affects migraine is serotonin. And a lot of antidepressants also deal with serotonin, which may be why they are helpful in migraine prevention. So tricyclic depressants are kind of an older antidepressant, and so there are a lot of different meds within this class, things like amitriptyline, nortriptyline, doxepin, disipramine. All of these medications are tricyclic antidepressants, but they all are slightly different because they work on the receptors differently in that they have, some of them may work with a higher likeness or affinity to the serotonin receptors versus some of them might have more likability to a different receptor, such as a histamine receptor. And so that's where we get the differences among this antidepressant class. And that's why sometimes we'll provide you, an alternative within the same class. So they're both tricyclic antidepressants, but they have a different receptor profile, which means they can work differently for you. And also for that reason, they can have different side effect profiles because they work on different receptors or have a different likeness for different receptors. So for instance, some of these medications, such as nortriptyline and amitriptyline, can make us very sleepy. But if those make you too sleepy, then maybe something like disipramine might be a better option for you because it's still a tricyclic antidepressant, but it's less known to cause drowsiness. So that's really kind of important to know, even among all of our other antidepressant classes as well, is that trying different ones is really important. And we really appreciate that you guys as patients are willing to kind of experiment with us to find the best fit for you. Some other side effects with these medications are that they can cause some dry mouth. They can also increase your cravings for sweet and salty kind of snacks, which does in turn make some patients gain weight. Generally though, if you go into the mindset knowing that these types of medications will cause those cravings, you can curb those before they really cause your weight gain by keeping some healthy snacks around. With all of our antidepressants as well, we want to make sure that no one is stopping these medications abruptly. And that really goes for all of our medications, actually. There can be really serious risks if we do withdraw medication too quickly. Certain medications do have a worse withdrawal syndrome than others, but we like to prevent any sort of adverse effects from stopping a medication too quickly. So unless you have an allergic reaction to a medication, definitely do not stop anything without calling us or your doctor and letting us provide you a schedule to safely get off of that medication. So I would say the most common antidepressants used in the US are called selective serotonin reuptake inhibitors, SSRIs. These are medications like Prozac or fluoxetine, Zoloft or sertraline, Paxil, paroxetine, Lexapro or escitalopram, and Celexa or citalopram. You may have heard of these names before. They're really good at antidepressants, anti-anxiety medications. They work great for panic disorders, obsessive compulsive disorders, and they also work great for migraine prevention. So these are a really great option, especially if you have been feeling low lately. This can really kill two birds with one stone and is a great option for a lot of patients. Some patients tolerate these very well and report no side effects. Others can report some drowsiness, and this can be different based on the antidepressant that you're taking. For instance, Prozac is thought to be a little more activating, doesn't really make people drowsy. However, Celexa might make people drowsy, although it's not common. Again, we don't want to stop these abruptly, so give your doctor a call if you're thinking about stopping your medication. SNRIs work on both serotonin and norepinephrine, which are two chemical neurotransmitters in the brain. These are things like Cymbalta or duloxetine, Effexor or venlafaxine are the two most common of this class. And they could be used for migraine prevention, which is what we're talking about here. They also can be used for depression and anxiety, like our other antidepressants. And they can also be used for pain. SNRIs, thought to be maybe because they do have that other component, have been studied and have, shown good benefit in pain. Certain types of pain, mostly like neuropathies and that type of pain is what we might try this on. Again, you do have some side effects. Some people can have some dry mouth, maybe some trouble sleeping. And along with the SSRIs and SNRIs, some people will report sexual problems with these medications. Some people will not. That's definitely something to talk to your provider about if you do develop it. Other antidepressants are things like Wellbutrin or bupropion, Remeron or mirtazapine, Trazadone. These are medications that can also be used for migraine prevention. Bupropion is also something that can kind of help with fatigue. It's, it works on dopamine, and so it can be kind of activating for people and give people a little bit of a boost in energy. But sometimes the other side of giving people a little bit of a boost is too much of a boost can cause some anxiety. So that is a side effect that we do see of Wellbutrin sometimes. Also in someone who has pre-existing seizures, if you have a seizure disorder, bupropion may lower the seizure threshold, which means that it may make your brain a little more susceptible to a seizure. So that might not be a great option for you if you already do have seizures. In the general population, this is not thought to be a real concern. Remeron and Trazadone, in addition to being really good migraine preventives and also good antidepressants, is that they're really helpful for sleep. So if you're having some trouble sleeping, some of our antidepressants might really help you prevent your migraine and also get you good sleep, which can also be very helpful for your migraine. Special medications that we would think of for sleeping would be things like Trazadone, mirtazapine, or some of our tricyclic antidepressants like amitriptyline. Some other medications that we think of for migraine prevention, we're wrapping this up now. Memantine or Namenda was actually originally approved for moderate dementia or loss of memory in the elderly population. And so it was really interesting to find that memantine was actually helpful in preventing migraines. It's generally a very well-tolerated medication. Sometimes people do concern with some gastrointestinal upset, but otherwise, in my experience, it's been very well tolerated, which is great. And finally, before we get to our new medications, we have Botox. Botox is generally, we consider it after we've tried some of these other oral by mouth medications, and Botox is injections that are given in different areas along the face and down back of your neck to prevent migraine. And Botox injections actually are FDA approved to prevent migraine, so that's really helpful that it has that data to support it. Unfortunately, they aren't very well covered for migraine. You do have to try some of these other medications first. They are injections, but they are not thought to go, systemic. That's not their point. And so the side effects are generally just kind of local. You can have muscle weakness locally. Some blurry vision or drooping eyelids based on where they're getting injected, and trouble swallowing would be more rare but is possible based on the injection sites. So those are some of our preventive migraines, treatment for migraines. And then we have our new medications. These are our CGRP injectable medications. We have 3 options. The first is, and it was first approved, was Aimovig or Arenamab. These are once monthly injections, and they're just subcutaneous injections. So they're just given either 2 finger lengths away from your belly button, or you could use the upper side of your thigh. Those are both great options for subcutaneous injections. We're not trying to get into the muscle, we're just trying to get into the layer under the skin of fat. And so somewhere where you have a little extra fat is where you want to get these injected. They're very easy to do at home. They have, each of these 3 does have their own injector. So you do have to kind of, you can come into the office and see which one you like the best. But they all are kind of auto injectors, so you don't have to actually see the needle or anything like that. They're really easy to administer, and most people don't even bleed. They're very nice and very convenient how they've been developed. These medications they either block the receptor to make sure that the CGRP peptide can't attach, or on the other hand, they can block what's known as the ligand. So the ligand, the receptor is free, but the ligand that is supposed to attach to the receptor is changed so it can no longer attach. So if we're thinking about this in terms of like a lock and key, the Arenamab or Aimovig works on the lock to change the lock so the key can no longer get in, versus our other medications, Ajovy or Emgality, will change the key so it can no longer get into the lock. So there are very many differences between these medications. They both work on they all work on that same peptide. There's a bit of a difference in dosing. So the Arenamab is a monthly injection. You start off at the same dose. You can increase your dose if needed. There's either a 70 milligram or a 140 milligram option. And then they're given once monthly. The Ajovy is really interesting because you can get 225 milligrams monthly, or you could do a 675 milligrams or inject 3 injectors at once and then not do anything for 3 months. So if you're someone who likes to do things as little as possible, every 3 months might be a great option for you. The last medication, Emgality or galcanezumab, it actually has a loading dose. So your first month you do 2 injectors, and then every month thereafter you just do 1 injector. So it just kind of loads you up. So a little bit of different dosing strategies there, all trying to achieve the same goal. And in studies, they did have pretty comparable effectiveness and efficacy as far as reducing migraine days in patients with episodic migraine, so less than 15 headache days per month, or chronic migraine or greater than 15 headache days a month. This can be helpful for either patients. And as far as side effects, they're also very manageable. The main side effect with all these medications is actually a slight injection site reaction, so maybe some redness around where you injected. That's pretty common, but again, in our experience here in clinic, not many people have been concerned about their experience. One difference, though, may be that Aimovig or Arenumab, the one that works on the receptor, does have patient reports of constipation. So if you do suffer from constipation already, perhaps Ajovy or Emgality might be a good option for you. And now we'll just kind of switch gears really quick to our acute treatment of headache. So we went through the preventive treatment of headache, the things that you take every day for those oral medications or once a month for those injectable medications, and you take them consistently, and you're super adherent to prevent those migraines, and you try them for 8 to 12 weeks nonstop to see if we can get your headache days down. On the other hand, we have our acute treatment for migraine, which is what we'll discuss now. These are medications that you take when you feel migraine coming on. And it's important that we actually don't use these acute treatments too often because they can cause a rebound headache or a medication overuse headache. So that's a specific type of headache that only happens if you're taking too much of your acute medication. So really important to distinguish what is your preventive medication and what is your acute medication. What do you take every day versus what do you really need to be using sparingly? And if you have questions about your personal regimen, please get in touch with us or your provider because we can help you out with that. Our most commonly used migraine medications are the triptans. That's the class they're known as because they all end in triptan. So it's important, like with our antidepressants that I was talking about before, but here we're talking about acute treatments, you can respond differently to one triptan over another. So if you failed one triptan, say it made your headaches worse even, do not be afraid to try another triptan. Often, a patient may have to try 1, 2, or 3 other triptans before they find one that they feel works for them. So do not lose heart. Our triptans, our options are sumatriptan, rizatriptan, zolmitriptan, elatriptan, almotriptan, naratriptan, and frovatriptan. So these medications, like I mentioned, are a little bit different from each other. We have our medications that are generally shorter acting versus our triptans that are generally longer acting. So like frovatriptan is one of our very longer acting triptan medications versus something like sumatriptan would be a shorter acting medication. And they do come in different formulations as well. So they all come in an oral formulation, but sumatriptan also comes in an injectable formulation. Zomig or zolmitriptan comes in a nasal spray formulation, and others come in other formulations as well. All of these are thought to be, the nasal sprays and the injectables are presumed to be shorter acting, and they get into your system fastest. Which can be really helpful for your headache, or if you're someone who experiences a lot of nausea with their headache and you can't get the nausea medications or they're not helpful for you. These medications that avoid taking things by mouth can also be helpful for you to make sure you get the medication in your system. Some side effects that we do have with triptan medications can be something like a chest pain or chest tightness just initially, and that is kind of typical to triptans. And so, if you do experience that side effect, we might try a different triptan to see if you have a better response. Ergotamines are also a form of medication that we use for acute migraine treatment. Dihydroergotamine is available as tablets, or injections rather, and a nasal spray formulation as well. So dihydroergotamine is a pretty powerful medication and can work very well, but it also is very well known to cause nausea. And we'll talk about nausea medications in a little bit, but this is definitely a class of medications where nausea medication pre-treating, which would be probably recommended. The IV formulation is generally something that we reserve for a healthcare setting. If your provider offers in-clinic injections or IVs, that might be something you could get in clinic. There's also kind of a 3-day protocol that we sometimes use with our admitted patients. If they really have an intractable migraine, they just cannot, have not been successful in treating or breaking that headache cycle, and they do need an inpatient admission to break that. Dihydroergotamine injection might be something that we would employ. Ergotamine is available as oral formulations. So Ergamar is a sublingual tablet that's just ergotamine, or there's an oral formulation with caffeine called Cafragot. Cafragot, so the caffeine in ergotamine is also available as suppositories. These, again, may cause nausea. They're generally less tolerated, so they may have more side effects than our triptans. And so we generally do not use them as our what's considered our first line or the first things we might offer you. And they do have some drug interactions, our ergotamine, so that's something to keep in mind as well. The tough thing, with triptans and ergotamines is our patients with some underlying cardiac risk factors. Because I said, the triptans can have that, passing chest pain, for those reasons, someone with a cardiac history is not really a good candidate for ergotamines or triptans. Luckily, there are medications in development that are similar to these that don't carry the risk. But as of right now, if you do have any cardiac risk factors, probably we wouldn't be looking at these options for you. Some other things that we can use for acute migraine treatment are combination products that you may have heard of. Midrin is a combination of isometheptine, Tylenol, acetaminophen, and dichlorphenazone. So this is a combination of a couple different, agents that work differently that combine together to help you to treat your migraine. So these can work for, your primary migraines. They can also work for vascular or tension headaches. So they can be a really great option for you. Furostet or Furanol are other medications that are combinations. So Furostet contains caffeine with acetaminophen and butalbital. Versus Furanol, which has caffeine, butalbital, and aspirin. So really the only difference between those two is the aspirin versus acetaminophen component. These medications can be helpful, for acute treatment of migraine. All of these medications that I mentioned can contribute to those medication overuse headaches. Perhaps the Furostet and Furanol can contribute faster to those medication overuse headaches. So we want to be sure that you're not using these medications more than is recommended, which is usually about 10 times per month. In addition to our acute migraine treatments, we often will prescribe a nausea medication. Sometimes in the setting of migraine, our gut system, our GI tract is not really working as well as it can. And the problem with that is that a lot of our oral medications, so say you're on an oral triptan, in order for that medication to work, it needs to get into your small intestine in order to get absorbed to where it needs to go. So if your gut isn't working and it's not working to get things where it needs to go, or it's going slower than it usually goes, then you're not going to get the relief that you need to as quick as you need to get it. So an anti-nausea can be very important to get things moving, as well as to treat any nausea or even to pre-treat any nausea that does often, in sometimes the majority of cases, go along with migraines. So medications that we use for this, words you might have heard of, Reglan or metoclopramide. This is a great option. It actually is FDA approved for something called gastroparesis, which is similar to what I just mentioned, where things just aren't really moving. There's slow down in your GI tract, so things aren't getting moving. So that's a great option. Rarely metoclopramide or Reglan can cause some abnormal movements, so keep that in mind. But generally on a a low dose as needed for migraine, this doesn't generally tend to be an issue. Other medications that we use are prochlorperazine or compazine, promethazine or Phenergan, or chlorpromazine as well. These are all medications that are used to treat migraine, migraine nausea, but an added benefit of these medications is they actually can help to treat the migraine itself. So we've got these medications that work to help the pain of the migraine and the nausea of the migraine, so they're really great options. Our last medication that is really good for nausea but doesn't necessarily help with the migraine pain component is Zofran or ondansetron. It's a really great option. We can offer it as an injectable for acute migraine issues. In the, in an ER setting, in a clinic setting, if they do offer injections, and it's also got an oral and a sublingual form. A lot of these other ones also are available as acute treatments as well. Reglan has an IV formulation, as does the prochlorperazine and the chlorpromazine, and Phenergan does as well. Although it does have issues with the IV formulation of the Phenergan, it can be given, these medications can be given intramuscular as well. So those are medications that you can take at home. Usually we prescribe a migraine cocktail for you that would include an anti-nausea medication as well as, a triptan or one of the combination products that we mentioned. So maybe take Zofran plus sumatriptan at the onset of your migraine. That might be a typical migraine cocktail that we'd see. Now, say that doesn't work. We have a saying in migraine that if all else fails, get to sleep. So we do have some medications that we use for kind of acute treatment of sleep. A couple of the medications that can work well for this are of our benzodiazepine class. So you may have heard of lorazepam or temazepam. We do not like to use these often. They are really reserved for intractable headache cycles. They've been keeping you up at night so you haven't been able to get to sleep, or you just need some good sleep to break that cycle. These medications are really reserved for those situations, but they can be helpful in inducing sleep. Benzodiazepines, of course, have their issues, especially with the long-term use. They can promote dependence, which is, of course, something that we do not want for our patients. Long-term use of benzodiazepines also has been linked to risk of dementia. So a lot of reasons why these are not long-term medications. They are not preventive medications for your migraine, but they can be used in those intractable scenarios. Ambien or Zolpidem is something that we can also use in those in just very intractable situations. Again, not for long-term use. Ambien is linked to, sleepwalking and other activities of sleep, in addition to, daytime fatigue that lingers overnight and can impair function and thinking. So again, just really those intractable things, but just know that even if your migraine cocktail fails, just work with your provider. There's always other options. And so that's just kind of my rundown of our preventive and our acute treatment options for migraine. Preventive options, again, are things that we take on a daily basis to prevent the onset of migraines and prevent your total headache days. We have a lot of great options that we have in our arsenal and are very excited about the new options that have come to market just in the last year. We always will recommend for you a preventive migraine option as well as an acute migraine option for when you do have those migraine attacks. If you have any questions, please feel free to get in touch with us, and we're happy to answer the questions, any questions that you have, and we're excited to work with you in the future on getting your headaches under control. Thank you guys so much.